production for your enjoyment today. I'm Carol Swallow, the chair of the Department of Surgery. And on behalf of my chair colleagues, I'm going to just keep going. Beverly Orser from Anesthesiology and Pain Management, and Kelly Murphy from OBGYN. I would like to welcome you to these special combined rounds, which is something we've never done before, the three groups all together. And so we're expecting, and I think we're materializing into a fairly big group here this morning in the auditorium live. I was just saying it's a combined rounds with OBGYN and anesthesia and pain management. And I want to welcome everyone who's here in person, and also I think we have quite a large group of people participating online. So to begin with, please scan this QR code because we're going to have some questions for you shortly after the next couple of slides. So prepare yourselves. Surgeons are used to being prepared. I'm not so sure about anesthetists. So come on in. I want to just start by acknowledging some of the planning committee members and the people that you're going to see acting and participating live and on video this morning. This has been quite an undertaking to put together, and I'd like to acknowledge Chriselle Evangelista, who did almost all of the organizational work and will take the blame for anything that goes wrong. I'd also like to acknowledge the fact that the land upon which we are meeting today and upon which the University of Toronto operates has for thousands of years been the traditional homeland of many Indigenous peoples, including the Anishinaabe, the Haudenosaunee, the Mississaugas of the Credit, and the Huron-Wendat peoples. And it continues to be the home of many Indigenous peoples today. So we are proud and happy to work on this land, but we also acknowledge the historic injustices that have been done to our Indigenous colleagues, friends, and family members, and we seek to do better in our relationships with them and with the land in the future. Ashlie, are you there? Yeah, okay, she's coming up. Ashlie Nadler did a lot of work contributing to these grand rounds, and she's going to moderate the Q&A. Go ahead.
Thanks, Carol. So that was an excellent skit or real dynamic that we just saw, but we've had the opportunity to put together a video that demonstrates another interaction in the operating room. I hope that you find it realistic, and I believe this is a situation we all encounter quite frequently. So we're going to show this video, and then we will have our panel discuss.
Ashlie, we're doing the questions first.
Oh, the questions. I'm sorry.
Yeah.
Thank you. Okay, so we'll talk about what you just saw. And this kind of conflict around prioritization of cases occurs in the OR environment in which I work. Seldom, occasionally, or frequently.
Yeah, so we've got about 50% saying frequently, which I think reflects most people's experience. Okay, next question.
This dispute should be resolved by, choose the best answer, application of clear algorithms, escalation to a higher authority, or direct discussion between the surgeons.
There's some algorithm believers out there. Okay. If you've ever tried applying them. Okay. Next question.
Nurses often bear the brunt of surgeon discontent about factors for which the nurse is not responsible.
Close to 100% agreement from all of us. And I should add, there are lots of nurses here online and in person. So thank you all for coming. Next question.
Learners model their behavior on that they observe in their teachers.
Okay, also near 100% agreement. So now welcome the panelists up to our table here. So Colin McCartney, the head of anesthesia pain management at Sunnybrook. Caroline Moulton. Caroline, what's your title again at UHM? Cognition and culture lead in the OR, perioperative team. And Caroline's an HPV surgeon at Toronto General. And we have Jasmine Chung, who is a nurse at the Holland Center. And Peter Ferguson, who is a orthopedic oncologist at Mount Sinai and the chair of the Division of Orthopedics for the university. So we've chosen them to give slightly different perspectives on similar questions. And Kelly Murphy, where's Kelly? Kelly Murphy, chair of OBGYN, is going to co-moderate this with me. Are we going to give her a microphone or we'll just be together? Okay, all right. Okay, so Dr. Ferguson, we're going to start with you. The surgeon's response to the situation in the video seemed a little bit over the top, maybe a little bit extra. Do you think the reaction depicted in the video is based in reality? And if so, why is having your case canceled or even the threat of it being canceled so triggering?
Yeah, I think it's realistic, maybe a little over dramatic, but I think it's pretty realistic. I think the surgeon alluded to one of the factors that it's challenging. It's challenging for us to go to a patient who has worked himself up for surgery, which is clearly a very traumatic experience. So work themselves up and say, look, it's not going to happen today. So I think we all, sort of find that very, very difficult conversation to have, to say, look, you got to go home, or we've got to go and plan this process again. I think it places a lot of extra burden on us and our office to rebook that patient, move patients around in order to accommodate things. I don't know whether we admit it or not, but there's income impact on us not to get those cases done. Teams that work efficiently, ultimately that will, help everybody, but it also, allows people to make a little bit of extra income potentially. So that may be some subtle pressure that is underlying some of those reactions. So those are a few things off the bat that come to mind in terms of why that is such a challenging situation to deal with.
Just to follow up, the belief that surgeons always overbook their allotted time is pretty pervasive. Is it true? Is it intentional? And what do you think explains this pattern of behavior or the perception by others?
Yeah, it's hard to say if it's always the case, but I think probably largely, I think we're notoriously bad at predicting the duration of our cases. I think we dramatically underestimate how long cases are going to take. I think we all feel the challenge of predicting the unknown factors that would affect the duration of these cases. So I think there is accuracy certainly to that statement that we frequently do sort of overbook our cases, and certainly one thing I would say to the surgeons starting out in practice when you get there is try to avoid falling into that trap. Try to purposely underbook your cases so that you're not at the end of the day dealing with a situation like this.
Dr. Moulton, overbooking is often cited by anesthesia and by nursing as a major source of conflict in the OR. Do you have anything to add to Dr. Ferguson's insights?
I think one thing that I feel we do often is, as individuals, we kind of get put into this scrap, and we kind of, we're forced to kind of manage our own issues every time. And I think if you look at it, this is a kind of happening a lot across all of the ORs. And we're not bad people. Like, we're all good people trying to get our kind of, the goals that we have set met. And I think one of the things that happens is that we all are trained in our individual silos. So the nurses are trained in the nursing silos with assumptions that are made against other, what surgeons think, and anesthesiologists are trained in their silos, and surgeons are trained in their silos. And then we kind of get thrown together in this operating room kind of tense environment and wonder why these things keep happening a lot. I think the solution probably should be more of a system level solution, like rather than expecting individuals who aren't kind of trained in necessarily conflict or trained to understand, perspective taking, a system solution to work out how we actually work as teams and how do we actually bring each other's perspectives together so that we can actually talk through things and not make these assumptions, or really kind of challenge us to examine each other's assumptions about the other disciplines. So I think that's kind of always there at the forefront. The assumptions that we make about other people, because we're brought up in this discipline with socialization and the hidden curriculum, we think that surgeons always will overbook. And even before the argument starts, you're kind of confronted with that. That that's what these people are thinking. And so when the clipboard walks in, or the person with the clipboard walks in, you start sweating and you start thinking, oh, now I've got to tell this person, or now we have to have this discussion and it's not the good time. And so I think, rather than continuing to do this like for years on end, because it's been going on for 20 years since I've been here, why not try to find maybe a system solution, or how do we actually work better together as teams and explain and explore each other's perceptions and try to come together when it's very difficult over the patient. You're having this argument over the patient, but I think we just have to maybe take a higher level view. I mean, it's great to see it in play because you can see yourselves in that skit. So
can I just add, I think as surgeons, we have to, keep in mind that we're all there for the same purpose. Everybody in that room is there for the same purpose. So the anesthetists want to get the case done. I have no doubt nursing staff want to get the case done. So we all have a common goal. We think we're advocating for our patients. I don't think we have to advocate to the nurses and the anesthetists for getting the case done. We also have to keep in mind that, especially the charge nurse is there advocating for and owes responsibility to all the people who are having surgery done that day. So certainly they want to get that case done, but they have many, many other patients they have to advocate for. So I think, we're siloed, as you alluded to, and closeted for advocating for our own patient, but others are advocating for everybody who is having treatment that day.
Further on that, the surgeon in the video feels like she is the victim of the circumstances, et cetera. And she's, really doesn't see why she has to communicate that bad news because it's a failure to the patient and to the family. So what are your thoughts about surgeon responsibility for communication and situation? How should that happen?
I mean, I've been in this situation and it's not easy. Again, I think it comes down to, right away, I think the surgeon is feeling misunderstood, and there's a frustration that people don't understand the predicament that you're in, or people don't understand the pressures that you have. Even if we want to get that patient done, there's multifactorial reasons why we want to get the patient done, some of which we actually declare and others that we don't. Like, yes, you want to make an income, but that also, when everybody's there making an income, and we should talk about that. We should put it on the table like you did, which is great, because it's not necessarily that you're a bad person. Of course, you're making an income. So let's put that on the table, but it's not the only reason. I think the reason that was stated in the video, that you actually know the backstory for these patients. I think that it's the feeling misunderstood. So as soon as you see the person with the clipboard coming in, you actually kind of are getting ready for that conversation. And I'm sure as soon as the person who's kind of having to come in with a clipboard, they're getting ready for the conversation too. and it's a bit of because you feel misunderstood, you need to kind of throw it all out there, and then it's often in a passive aggressive way, because we know that the decision's been made. We don't really have a say in it. And we're prepared to stay there and do the case. And maybe it's only going to be in half an hour overtime, but this patient could then have the case done. And the system or the decisions that are made for purposes of overtime, they've made the decision not to proceed. And it feels like you're just, often, I think surgeons often do feel this, that it's their patient when the bad news has to happen, or it's their patient when a complication happens. And maybe the team kind of falls away, and it's not really the team's patient. So there should be no reason maybe that other members of the team or the hospital can actually go and tell the patient so that they can actually leave. I think it is the responsibility of the surgeon ultimately, but the responsibility, like anything, can be, what is the word? When you delegated to others. And I think that requires training on everybody's comfort level to go and talk to a patient. I think you do feel as a surgeon that unless you talk to the patient, you're not feeling the disappointment. It's easy just to cancel a case. But when you go into the patient and actually have to tell them, you see the tears, you see the frustration and the anger, and it doesn't seem right in a system when you were prepared to do the case that you're the only one that can actually, go and tell the patient, and you take on all of the hospital's priorities.
Well put. Okay, now a question for our nurse representative on the panel, Jasmine, Chung, and thank you again for being here. The charge nurse and the circulating nurse in the video come off like the bad guys who are obstructing patient care, at least in the surgeon's view. This is a common trope of the nurse as gatekeeper. Do you think this is a fair description of the role of nurses in the operating room? Did your training prepare you for this role? How do you feel about it?
No, I don't think that's an accurate description of a role of a circulating nurse and a charge nurse role. I feel like these kinds of situations do happen throughout our career, and it's hard to, I think it all depends on what your relationship is with the people that you work with, how many years of experience you've had in the operating room. It feels like we're always playing the role of trying to make the surgeon or the surgical team happy, but also our own nurses happy. I feel like if it becomes a pattern of where it's expected for nurses to stay overtime all the time, it does affect our livelihood and how we feel about coming to work and our energy level. And I think the whole dynamic of the work culture kind of shifts over time, even though it might not happen right away. I think over many months, people will see that. And I think in terms of being prepared with our training, in theory, yes, we do discuss how we can stand up for ourselves, how we can stand up for the patients in our training. But I think in real life, it really depends on your comfort level, your experience, and how you can vocalize in a professional way to meet everyone's needs.
And I mean, how do you, other than experience, how do you get to a point where you can communicate at this very sophisticated level? I mean, are you given opportunities to take courses or?
I think there are courses that are offered from the hospitals where you are given the option to maybe advance your leadership skills. I'm not sure how often it happens, but preceptorship, mentorship courses, I know that's offered at some hospitals. And I think just shadowing, when you are being trained to be in a charge nurse role, I know that you are to shadow a nurse to understand what their roles are exactly and how they deal with the situations. And I think as a nurse, we're having a good management and people that you can go to if something does happen, even though you may not be able to deal with the situation that you wanted at that moment. You kind of think about it and you can go to your managers, you can go to your educators and discuss what happened and figure out ways things that you've done well, things that you want to do better next time this situation happens again. So I think there's always resources that we can lean on. But it has to also come from you to want to seek that. Yeah.
Maybe I'll look at Carol to comment on this a little bit too. The, OR charge nurse, I think, must be just the most horrible role to play because everyone blames you. No one wants you to come into their room. Do you think there are certain people who are naturally inclined to be able to do that role, or is it a trainable skill?
I think both. I certainly have seen the two spectrums where you think, oh no, this is not a good fit. And they admit it, and they've kind of been put in this position where they feel like they have to have the conflict and they crumble, and you can see them kind of not doing well. And then others that kind of seem to just naturally take over and fly and seem to enjoy a little bit of the conflict and not kind of afraid of it. So I have seen both. I think the ones that seem to do well are the ones that are able to just take that higher road and just have this concept of being fair and just keeping fair in the back of your mind and not having difficulty and having difficult conversations. So I think both. And I think everything is trainable. Like all of this, I think is trainable. An example that I've just been thinking, how do you get around it? I think at one point, and you learn this in relationships, if your partner comes to you and says X, Y, and Z, your immediate instinct might be to be defensive. And so you learn in counseling, and yes, I've been to counseling, that you learn that your immediate thing maybe should be to pause and take a breath and slow down. And another thing you can do is actually think about their perspective. And then if you're bringing something to somebody that you think is going to be touchy, because we kind of know that walking in with a clipboard is touchy. And I think we know also that as a surgeon, the person coming in with giving that information is touchy. It's not actually easy. So just actually even saying, I acknowledge that this is going to be difficult to hear, or I acknowledge that this is a difficult spot you're in. Let's have a conversation about it. And often not in front of everybody else. Like, let's actually take this conversation somewhere else. I mean, just the mature things, just acting kind of mature and not accepting that you have to act in this role. You get some affordances, I think, in some of these roles to act a certain way. And I think just accepting that you don't have to, take that affordance. You can actually step out of it and be more mature.
While we're on this topic, I thought we would consult with one of our OR nurse leaders from Sinai. Just Tanya, if you could tell us, how do you help nurture your charge nurses in the OR, and how do you identify what their needs are?
Can you guys hear me? Maureen is our coordinator in the OR, and I think she does a fabulous job. And I know that role is very hard to recruit, so I'm the manager there at the OR. I did the clipboard nursing for a long time as well, so I know how difficult it is. But we often, when Maureen has a hard day, we often debrief in my office. There's an open door policy with any of my team leaders, coordinators, nurses in general, and like that. But essentially, I think that's an important part, that, I've had a horrible day. This surgeon or this nurse or this, whoever it is, anesthesia, has really come down on me hard. And so I think that's, it's not so much of, how do we train them, but it's just finding a time to support them and them venting as well. Because, to your point, they have to, you can't just start to have a full-out argument out there in the OR. It's just, for many reasons, not appropriate. And so coming in there and closing the door and swearing if she has to, and all of that, just giving her that time, and me then just listening, and so we fostered that relationship. I worked with her in 2 hospitals, and then with all the other team leads and the evenings coordinator now. So that was Lindsay that you saw on the screen. It's a lot of coaching more than anything else. There are leadership courses, there are conflict resolution courses. I think are very valuable. In theory, is great, but it's that practice every day, and then coming back after and saying, okay, what went well, what didn't go so well, how can we help you in the future? And there has been times where they've asked me to go and speak to a surgeon it has to be after though, it has to be 2 days later. It can't be right in the moment. And so all these sort of tips and tricks really have worked.
Okay, thank you very much. And for those of you online, basically, I'll distill Tanya's comments to open door for debriefing, regular check-ins, coaching, and opportunity for courses. And we'll use the handheld mic, I guess. Okay. Back to Jasmine. So who do you think ideally should be responsible for decision-making about emergency case prioritization and elective case cancellation? Can a detailed algorithm solve these problems?
I think ultimately it has to be a discussion amongst the surgeons of two different disciplines that are wanting to get their cases done, and the anesthesiologist and the team lead nurse has to be there. I believe that in terms of the status of the patient, or the medical status of the patient, is very well known by the surgeons and the anesthesiologists, like their lab values. Are they stable? Are they even stable enough to go into the operating room? And I think the team nurse is there to kind of mediate, like, is there an OR available? Are there staff available? Can we get this case done in a timely manner? Do we have all the equipments available? I think every discipline is thinking about different things that are required to provide patient safety care. So ultimately, I do believe it's a discussion amongst all three, the surgeons, the anesthesiologist, and the team lead. And in terms of the algorithm, I think if there's an algorithm in place, it works to a certain extent, but I don't think it can be assumed to be applied to every single situation, because every scenario with the patient and the OR status is changing and it's different. I've had situations in my career where the surgeon of the month had to be involved, but I think that was kind of like the last resort, if nothing was coming into conclusion. But I think if there is an algorithm that is to be developed, every single members of the discipline, like anesthesiologists, the surgical team, and the nurses have to all agree and come to an agreement before it's released.
Dr. McCartney, we all know that surgeons often blame anesthesia for delays that result in case cancellation, wondering, did they really need that extra art line, honestly? And anesthesiologists sometimes blame those surgical trainees for slowing things down. How does this narrative of blame affect the working relationships in our OR?
Yeah, it's funny, there's an old colleague of mine at Toronto Western, Jacob Lye, that used to say, the surgeons always say, take your time, just not my time, take your time. Well, listen, first of all, I just want to say what a pleasure it is to be here today. I know many people in the audience. I've worked in two sites in Toronto, at UHN, and then at Toronto Western and Sunnybrook over the last number of years. And I worked with lots of great teams, lots of great surgeons, nurses, and anesthesiologists. I know that we'll come to work to do our best. So I think blame is unfortunate. It's a natural human instinct, but it doesn't help. I think there's a number of things it undermines. I think it fractures trust within the team. I think it starts to make things personal as opposed to making a system issue. Unfortunately, I think it silences the most vulnerable in the team, or the most junior members of the team. I think, as we saw in the video, the resident is often watching this and saying, is this the way to get things done, or is this the way that I should behave? I think it normalizes being uncivil to each other. And last but not least, as a leader in the ER environment, it's exhausting to manage incivility. And I have to say, and I said to Gianni earlier on, it's uncommon. And I know we at the boat and we do see some of these lower levels of incivility commonly, but outright unprofessional behavior is uncommon in my experience. And I've just come back to what I said originally, which is that we work with great teams, and the vast majority of people I work with, and especially with people like Jasmine at the Holland Center, for example, I almost always come away with a day at the Holland Center thinking that was a great day, working with a great team. And I think we have some great leaders across our institutions that are models of behavior in the operating room, building trust and building the ability to work together. And ultimately for our patients, which is why we're all here.
Just to further on that, why do you think it is important for us to improve civility in our discourses in the operating room?
Well, I think the most important reason is that it harms patient care. Incivility undermines our ability to speak with each other, to raise concerns, to optimize patient care. And there is evidence that incivility in the operating room environment decreases our ability to speak up, which can lead to worse outcomes for patients. I think all of us, I know, are invested in that. So that's the biggest reason. But then there are actually costs to the healthcare system. Incivility makes hiring harder. It increases our turnover of staff, which is a very expensive thing to manage and replace. I think conversely, civility and an environment where people know that there's a great work environment is attractive and attracts people, and that is very beneficial over time.
Going to open it up to the room and to folks online. Any comments? Somebody? Yeah.
Hi, it's Sylvia Perry from the Department of Surgery. I'm reading questions from online. There's two questions that are kind of related. So I'll kind of read both of them because I think one answer can probably suffice. The first question is, does having pre-conversations early on help from anesthesia surgeon's perspective, anticipating delays? The second question is there another option for timing of discussing a canceled case rather than during another case? Current practice has the potential for safety issues for patient on the table as distracting to the surgeon and the team.
Jasmine, can you comment on that? Is there another time when you could talk about canceling the last case?
I think there is an appropriate time in any situation to discuss that. Sometimes we look at the list and we do think in our heads, wow, there's a lot of cases for the day. But I think you have to see the flow of the room and how the cases are going. Sometimes a revision case might not be as complicated as it was initially booked or vice versa. I think the best time for the discussion to happen is maybe a case before or two, and finding that right time, not when they're doing the most crucial part of the surgery, but maybe when they're closing and the staff surgeon does scrub out a little bit earlier, and when the residents are closing, maybe that is the appropriate time for the discussion to happen. I don't think it's appropriate to discuss too early on during the day, just by looking at the list and kind of assuming what could go wrong. Because I think when the surgeons hear, oh, do you think you'll be able to do your last case? They will definitely not like to hear that. And I think that can also change the mood of the working day.
Is it a different point? Okay, I'm gonna just ask Peter. Peter, I've noticed that you're like Teflon. Anybody can come in, say anything, doesn't seem to bother you at all. Is this all an act, or how did you learn to be like that?
Yeah, it's I reflect on that and try to figure out where that came from. It's not an act. I mean, I don't act that way at home either. I don't blow off steam at my kids or anything like that. I just don't find that's in my nature to yell and scream and kick things. And I think probably one of the reasons is that I've found that a positive response, as much as you can have, I think in the long term is really beneficial, right? So if somebody comes in and says, look, I'm just afraid we can't do your last case, and my only response to that is, okay, thanks very much for letting me know. I'll let the patient know. And if you do that enough times, then I think the team is going to be much more willing. If you've got some extenuating circumstances, somebody who really, really desperately needs that case done and you're running behind, you say, and explain it quite clearly. Look, here's a sort of an exception to my usual routine. This is somebody who I really think needs to get their surgery done. Then I think the team will be quite a bit more willing to bend and allow you to proceed. So I just find in the long term that it's much more beneficial ultimately to patient care to have that response.
Dr. Forbes?
Yeah, first of all, I just want to commend everybody for this panel. It's outstanding to bring this multidisciplinary together. But just a couple of thoughts. I think, we talk about the OR being a stressful environment, and it is and it isn't, right? I mean, except for the very sick patients, the complex surgery, the hemodynamically unstable patient, it's really our sweet spot, right? It's where we want to be. It's where we do and it's where a lot of us are the most calm. It's where we want to be. It's really the external pressures that we bring into the OR that make it a charged environment. Jasmine may be facing staffing issues. There may have been sick calls this morning. She's got competing pressures. She has to limit overtime because of budgetary pressures. But on the other hand, she wants to allow patients to get. Surgeon may have come from a contentious M&M rounds, or there was bad weather and a snowstorm and getting late into work. Also is getting pressure to get long waiters done, as it was noted today. Has the expectations of the patients and their families, as well as the pressures of TES scores and teaching evaluations that say you've got to slow down and allow more independent operating room by the residents. So there's competing pressures. The anesthesiologists have a lot of the same pressures, and they may be environments. They may be covering the pain service. They may be covering another. Have to be teaching a junior resident. So similar pressures. So we get these competing pressures and expectations that we bring into the OR. We assume that we're alone, right? And nobody understands our pressures. So when we're prodded with, are you going to get that last case done, or some pressure, we react. So I think, Carol Ann has done a lot of work with the surgical safety checklist, which is done variably across the Tasman hospitals. Going from, it's not performative, it's actually a function. It could be a team building at the beginning of the day. Let's assume best intent of everybody in the operating room. How can be the efficient team to provide excellent timely care? It's an opportunity to bring the team.
Yeah, I think that's very well said. And one of the themes we wanted to bring out was that we make a lot of assumptions about each other that we get dug into, and we need to sort of refresh that somehow. More questions online. Sylvia?
Okay, so there's a whole bunch of different questions. One is, as a more junior surgeon, I find it difficult to balance the competing pressures of teaching and resident learning, resident operating with all the other challenges that have been discussed. How have senior surgeons managed this?
Okay, so we'll, I think, maybe go to Peter with this one. And then I would like Colin to comment, because I feel like sometimes the anesthesia residents get all these opportunities. We'll come back to that. Okay, Peter, go ahead.
Yeah. So I think this comes down to, planning your time throughout the day. And we chose to work at teaching hospitals because of the enjoyment and benefit of working with trainees. As a result, we have to plan our days to allow time for learning. So, if one of my colleagues, wants to do 5 or 6 hip or knee replacements in a day, teaching hospital is not the place to do it. They're going to be working out in the community, right? So where they don't have learners and they can do those cases themselves, right? So I think it really just comes down to planning your day, ensuring that there's extra time set aside to enable the learners to achieve what it is that we want them to achieve, and that's their sort of surgical efficiency.
And I know you're very good at that and sort of anticipating, expecting, but not all of us are so organized, or the cases don't seem to be so predictable. And then we get into a bind where, and I'll come back to the anesthesia resident at the beginning of the day, the 6th attempt at the epidural, and then the 6th attempt at endotracheal intubation, and let's try this art line one more time. Colin, are you thinking about the surgical trainees and their opportunities?
To be honest, it's not the top of my mind, and it should be. And I tell you something, I've got a couple of good friends in Toronto who are surgeons, and I enjoy speaking with them in an environment where there's no tension, and they're in different institutions, so I can pick their brain and find out what's going through their head. And it's very, very illuminating for me as well. I'm like Peter, I love working with our residents and fellows and medical students. And to me, it's one of the great pleasures of working in an academic environment. I do think there's a responsibility on all of us to make sure that our learners get their learning opportunities, but also they're not taking that sixth attempt on the arterial line. We do need to keep track of when our learners are maybe having more than a couple of attempts, not just for time perspective, for the patient. You know, I mean, they're learners for a reason. They're learning a skill, and sometimes we do need to step in and take over. And I think we should have that in the back of our mind at all times when we're working with learners, whether we're surgeons, anesthetists, or nursing staff, to be honest. I think there are opportunities as well where we can take some of the anesthesia control time out of the operating room, and that can be very helpful. We have block rooms in many of our institutions. At the Holland Center, where Jasmine and I work frequently, there's a block area where we do a lot of our induction of anesthesia prior to going to the operating room. And that can be very helpful for a number of reasons, including taking the learning experience out of the operating room for the induction of anesthesia, allowing research in those areas as well, and also it actually improves patient care when you can do that. And we do have that opportunity in some of our areas, both at the main but I think, you know, we do need to be cognizant of, number one, the learning for our learners, because ultimately they're going to be treating me in the next 10, 15 years. But at the same time, focusing on care for the patient and attention to when things go on a little bit too long.
Bev wants to follow up.
I was just mentioning we're a team and we all experience the pressures of the Canadian healthcare system. And here at U of T, we're the best position in the country, if not the world, to innovate. And we've got to innovate. And that's not just tools, it's the way we communicate. And that we have the shared view of the work we need to get done. And so I really thank Carol for organizing this rounds, but we do need to change our conversations. And so that the surgeon that has that one case in mind, advocating right on, but they don't have the perspective of what's sitting on the list. What the anesthesia team will have to flow around to get the work done. So I think we just need to think about our communication strategy, best practices, and how that changes, because the pressure's not going away. And we all want to work in a content, happy environment where we're feeling appreciated. So the conversations and our ability as a team to share the work, that needs to evolve as well at the University of Toronto.
Thanks. I'm Stan Hamster. I'm the Vice Chair of Clinical Teaching, and I'm a psychologist in the Department of Surgery, and I've been studying education for a long time. One of the things I'm interested in most recently is this idea of professional identity formation during training. And I'm glad that Colin said what he did, because I think that being a mentor, as you advance in your career, like Colin and I are, you get so much pleasure out of teaching and seeing other people grow. Once you get past the anxiety and tension of building your career, you get to a stability where you get great pleasure out of seeing other people grow and learn. So I'm just wondering, I mean, you talked about one of the questions in the app was about imprinting. It was like, would learners actually do, behave the way they saw the surgeons behave? And I think most people said yes. And, there's been great work by David Ash and OBGYN about where you train affects your practice patterns. So there's this heavy imprinting that happens during training. And you talked about the silos. I mean, Can we understand, what the nurses are thinking? Can we have empathy for people in different roles? And all this pressure towards being the specialist that you are going to become, all the anxiety that drives you to that point, kind of blinds you to the plight of other people who are developing alongside you. And I just wonder, it's part of the process. It's natural to want to create specialists and all the resources that go into that and the effort. But at the end of the day, you dump people out and they have to work together. So is this something that you can teach to individuals, and this is for anybody on the panel, something that you can teach to individuals along the way? Or is there a systems response in education that we can bake in this awareness of what it's like to be a charge nurse or what it's like to be people in different roles?
Many years ago, Glenn Regier, who actually put a challenge out to me and said, what would it, like you guys are all trained in your different disciplines, what would it look like if you actually trained early on? Like you had a student surgeon, a student nurse, a student anesthesiologist, a student attendant, a student whatever it is, and you actually came together as students some part of the time, some part of your training, and learned alongside together. And so you basically kind of cut out or cut through the hierarchy. You start to see the perspectives. You maybe take on different roles. It may come out in, we don't do that. And it's very difficult to imagine a time to do that, but it's not impossible where we'd actually be able to train, put them together. Unfortunately, though, when you get thrown out into the world, the hidden curriculum, states, you start looking at the person that you want to become, like that surgeon, and you admire them. And so their behaviors then, become something that you want to emulate. I was going to talk about a little bit of, something that maybe making the invisible visible is very important. And so the hierarchies that we actually have and that we work in is very important to kind of make that visible. And when you actually have a position of power in the operating room, it is something that is a privilege and not to be, like, you have to really check, the ways that you're actually taking advantage of that privilege. And how is your response different? I've often said my boss or my kind of person that I looked up to at some point was Bernie Langer. And then I would see surgeons who would be talking to nurses, and I would say to them sometimes in a challenging way, would you talk to Bernie Langer that way? If they were in, like, your scrub nurse, would you, if he was Bernie Langer, would you talk to him that way? And I think we have to really be reflective of that when we actually have positions of power. So hierarchy is invisible. We should make that more visible. Trust, we've mentioned that a couple of times. Trust is so important. And how can we get to the point of trusting each other? I don't think just throwing us together at a Christmas party or, those probably things that'll go some way to do it. But what is trust about? How do we trust each other if we actually don't even know each other's names? So I think that knowing each other's names is the basic thing, and then building on top of that and understanding what trust is about. I think that's where all of this comes from. When someone comes in to try to cancel my case, I don't trust that they know what I'm about, right? And they probably don't trust that I understand the hospital pressures. And so I think a lot of it is, yes, we have to do something innovative. I think we're in a good position, University of Toronto, to do something really amazing and to be the leader in the world, because I don't think this is just a Toronto thing. I think this is a whole healthcare thing.
I'm RJ Kuzumano. I'm a cardiac surgeon at Toronto General. That's for all the people online. It's just a comment, really. We talk about all the communications happening, and we know there's communication with the patient. I think that we need to do better with that communication when we're canceled. For instance, we all know that if we're running late, we ask for an extra case, we know we're trying to break the rules. But when you're late, for instance, your case goes on, and the nurses come in and say you're canceled, and you say fine, and then they say, can you go and tell your patient? Well, I can't tell my patient because I'm in the middle of a case. Can you have your assistant go and tell the patient that they're canceled? So this has happened to everybody in the OR. So I think we need to make a plan or innovate about how to break the news to the patient, because that's who we're all talking about. We're not talking about us staying in the OR telling jokes till 6 p.m. We're talking about a patient who's canceled. So I think we need to have an innovation about how do we break the news to the patient. It's not just on the surgeon, it's on the whole team.
Oh, yeah, go ahead, Jackie.
I just want to put a plug in for Mount Sinai. A group of us, Eric Montero, Aaron Kennedy, Naveed Siddiqui, and myself went to do that CMPA operating room course, and we all had to come up with a project. So our project was actually how to deal with cancellations in the operating room, quality improvement initiative, really about doing all of these things that we've been talking about. How do we break the news to the patient? The surgeon can't be the one doing it because they're the one in the OR, usually with a complication of some sort. So we actually came up with a whole process to deal with that. Who says what do we do for the patient? How do we rebook the patient, and when are they automatically rebooked? When is the surgeon going to talk to them? So that's a process that's ongoing at Sinai, and we're trying to get it put into policy, so it's something that's going forward. Now that was a couple of years ago. It's a long process, and just something simple like that is quite a difficult thing to try to get going. But anyways, those are the things. People are actually doing a lot of these things.
Yeah, it's Sylvia Perry again. So there's been a lot of comments online, very much like a chat discussion, and I can certainly make a document, and if people want to email me, I can forward it if you're interested in reading it. There's been a lot of common threads in terms of what's being said here and online. There is a comment further to what Carol Ann Moulton was saying. I found that if I know that a day is going to be challenging or overbooked, using the huddle first thing in the morning to plan the day is helpful. Where we can move more quickly, which part should staff, anesthesia, or surgeon take over from trainees? How will we ensure quick turnovers? When we are on the same page from the beginning of the day, we move forward together faster. But I think we could do this better if we knew our teams ahead of time and could plan by email for the day. Do other hospitals do this? So just kind of a food for thought for people to think about.
Any comments from the panel on that? Jasmine?
I have worked at an organization where the surgeon does gather the whole team in the OR and does like a day, like rundown of the day huddle. And if there's a new member in the team, like student nurse or new staff, we do all introduce ourselves to each other. And I think that's a very positive tone to start the day. And I think that in terms of like the turnover, just advocating for my nurses, we do work in a teaching hospital, and we do understand the residents, even the medical students, they're learning a lot of skills that are new for them. And sometimes I do find the staff surgeon will leave and let the medical students close, and because they left, they think that the room is going to be turned over as soon as they're done. And it takes a lot of like reminders, even for the nurses, to tell them like the closing took some time, and for us it's okay because we want them to learn as well. And I think in terms of nursing, we do have a lot of new staff now that are coming in, and we also have to teach them, and we want to teach them in a way that they feel comfortable to practice on their own when they're coming off orientation. And we also want to keep our nurses too. We don't want to lose them after a couple of months, having gone through all the training. They don't like the culture, they don't like the workflow, and they leave. So we all work as a team, and we do want the surgeons and everyone else to understand that the nurses try our best as well. And when the turnover starts, it's from the time that the room is cleaned, not when they leave.
Good point. And we'll give, there are two final comments. Colin and Peter both want to say something about this. Yeah.
Or just quickly, I think as surgeons, we can also go a long way towards improving the efficiency if we're around, if we have a presence along the lines of what you're saying, right? So ensure that we're there to help move the patient, offer to go get the patient, bring them into the room, all these things. So if we're off having a Zoom meeting between cases and, things are delayed by 5-10 minutes, and the end of the day, you're complaining because things have been inefficient, well, then you got to look in the mirror because you've been the cause of some of that inefficiency. So ensuring that you're around and contributing to that efficiency throughout the day, I think will curry favor with the team.
Colin?
Thanks, Peter. I really appreciate this. I find it very engaging when I'm working with a team who are trying to move things forward. I think and when I can see everybody's pulling their weight, I think that's fantastic. I agree with Jasmine. I like the idea of a huddle. I haven't worked in many places where we do have an early morning huddle, but I think it would be helpful for all the reasons that's been discussed. I also like the idea of expert surgical teams. And I know one of my surgical colleagues at Sunnybrook, Julie Halle, has done a lot of work on this area, and the way that outcomes can be improved by people who work together more frequently. So we've tried to move towards that a little bit by having directors in our various subspecialty areas and trying to have people who do work in areas more consistently. It's a work in progress, but I do believe from my own training in Britain, where it's very common that doing the same list or a similar list at least once or twice a week, you learn to get to know people, you know how they work together. I know from surgeons that I work with, I can tell even without looking at them that they're feeling stressed because of the way that things are happening. And then I can be more attentive and making sure that those are all things we get from working together more frequently. So anyway, the last thing I want to say is I love this and I'd love to continue this conversation. So I think there's lots of great things that can come out of this.
Okay, thank you. Great note to end on. And I just want to acknowledge all the people that contributed to this morning's rounds, and thank you for being here. To be continued.